Good afternoon and welcome to our Sepsis series. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interest. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker today, Dr. David Carlbom. Dr. Carlbom is Medical Director, Respiratory Care Department, and attending physician in the Medical and Trauma Surgical Intensive Care Units at Harborview Medical Center. He is an Associate Professor of Medicine, Pulmonary Critical Care and Sleep Medicine, Department of Medicine, University of Washington School of Medicine. He is a guiding leader for the Sepsis Forum, Bench, Bedside, Beyond, a volunteer group that brings cutting-edge sepsis science to bedside providers, patients, and caregivers. His passion is in early recognition and early resuscitation of critical ill patients. He is actively involved in leadership and teaching activities at the local, regional, and international level. He is a major resource for sepsis resuscitation and pre-ICU critical care expertise at UW-Medicine. He lectures extensively to multiple different professionals and works systematically to identify and initiate rapid treatment of critically ill sepsis patients. In 2020, he was awarded the Individual Global Sepsis Award in recognition for his commitment to educating others about sepsis. His bias is good people trying hard of any educational level can take great care of critically ill patients if they work as a team, communicate, and have compassion for humans. Join me in welcoming Dr. Carlbom.
Hi, team. Thanks so much for having me. First, I need to tell you that I come from, I'm sitting on Bainbridge Island near Seattle, and it's the traditional territory of the Coast Salish, the Duwamish, the Suquamish, the Tulalip, and the Muckleshoot. Not only do I honor this land, but I also acknowledge my country would not exist nor prosper if I weren't for the subsumed knowledge and free and slave labor of Indigenous peoples, African peoples, and other diaspora. Okay, I have no financial relationships with commercial interest. I have an intellectual bias that I think critical care is an activity that can be practiced by any well-communicating medical team in any environment. And I'm also a little bit of an early adopter, right? So I am this black lab among the sheep having a great time. I believe very strongly that with a good cup of coffee, a calm presence, and a well-functioning team that you can accomplish anything. I also believe that the initial resuscitation of sepsis is a medical emergency. So today we've got a lot to cover. I'm going to try to also get your thoughts with some just-in-time needs assessment. As a teacher, that's really helpful to me. And we're going to use a program called Slido. And so we're going to switch here, and I'm going to have you either use the QR code or go to slido.com on your phone. At the very top, there's a bar that says join, and the number to use is 33933. 33933. I'm going to ask you just a practice question. What do you enjoy most about the season of summer? Tell me what it is that you enjoy. Awesome. See, a couple people have found it. Perfect. Swimming. Oh, nice. I like that. Golf. Nice late sunsets. Yeah, come home from a long shift in the sun. Heat. Oh, guess it's good that you're in Georgia, not in Seattle right now. Baseball, beach trip, pickleball. Nice. Beach, lots of beach. Okay, I love it. Grilling. Okay, perfect. You guys are doing great. I'll close it down in about 5 seconds here. We'll move on. Nice. Vacation. It does look like beach time is winning. Longer days might be coming. Nothing in particular. Okay, even keel person there. Warm weather, family time. All right. Great. So you have practiced using Slido. Excellent. Let's move on. hopefully today, after today, you'll be able to describe pros and cons of using fluid for volume resuscitation, septic shock. Maybe when to add vasopressors to volume resuscitation. Talked about two fluid method assessments, two methods to assess fluid responsiveness, and maybe be able to, over a cup of coffee or other preferred beverage, debate the use of balanced versus saline for volume resuscitation. Okay, I do want to remind us all that there is a lot of inequity. So the Global Burden of Disease study looked at what percentage of a country's humans died of sepsis. And the higher the percentage, the darker the color. So you can see here in the continent of Africa, in India, in South America, a lot of people die of sepsis. It's women more than men from postpartum, and 40% of the global cases of sepsis are in children. So I hope that we're remembering this. And there's even, right, inequity across the United States, probably related to healthcare access, maybe related to social determinants of health, all really interesting stuff that I think we need to unpack more, because I think sepsis is the end product of dysregulated health. Okay, I'm assuming you all know the definitions of sepsis and severe sepsis and septic shock. That said, if you don't, you have some awesome local experts who are amazing. Please touch base with them for that Sepsis 101. So I'm going to dive into sort of systematic care, and we'll remind ourselves that the 3-hour bundle, as sort of established by CMS, is measuring lactate, maybe just as a surrogate for endogenous epinephrine. Obtain some blood cultures if you can. Administer antibiotics, maybe the most important thing, and giving about 30 mils per kilo of crystalloid for shock. The 6-hour bundle is use some vasopressors if they're still hypotensive after that volume resuscitation, reassess their volume status and tissue perfusion, and document, always the hard part in medicine, remeasure the lactate if initial lactate is elevated, which maybe never has saved a life, but is a clue towards your resuscitation. The New York State Sepsis Initiative was the first time a government agency, at the behest of lobbyists of a young child who died of sepsis, implemented sort of protocolized care. And their goal was that the 3-hour sepsis bundle was completed within 12 hours, and that some sort of sepsis treatment was initiated with 6 hours of ED arrival, looking at almost 50,000 patients. It does look like they did pretty well, right? This is places with, this is before COVID, places with busy emergency departments. Their median time to complete the bundle was about 1.3 hours. Antibiotics, a little under an hour. It's actually really good. We can't do that well where I work. And it looks like it's associated with higher risk, associations with higher risk of mortality were delay in completion of the bundle. As you can see in the gray graph, every hour your mortality went up. Delay in starting antibiotics in the blue graph, every hour delay, mortality goes up, but maybe not so much at initiating fluids. Interesting. Mortality stayed kind of the same whether your fluids were, your bolus of fluids were completed within 1 hour or completed within 12 hours. So I'm going to ask another question here. And that is, does bundled care for sepsis save lives? So private, we won't know your answer. People saying yes, of course. Yes, but maybe not the most important thing. I don't know of any proven benefit, or not so much. Give you about 30 seconds here. You guys are doing great with Slido. I'm glad to see that you believe that bundled care has a role, and we'll finish in about 5 seconds here. Nice. So the majority says yes, of course, and then a large minority says yes, and it's maybe not the most important thing. Perfect. So you're right. it appears many of you have seen this relatively recent observational study from the Providence Health System. So Providence has 54 acute care hospitals in the US, mostly on the West Coast. This was looking from 2020 to 2022, about 105,000 patients hospitalized for sepsis. About half of those had a sepsis order set used, bundled care order set, and the other half did not. And if you look at duration of hypotension, it was less in the bundled care order set. Hospital mortality, less, 9.7% versus 16%. Length of stay, shorter administrators. I think that's a good thing. Discharge to home, a little bit more, and cost was less. And so if you look at that reduction in mortality, number needed to treat is 11. So treat 11 people by initiating a sepsis order set to avoid one death or discharge to hospice. This group this year did a follow-up study to that, another similar cohort where they had more data, about 97,000 patients, about half receiving the order set. They matched, using propensity scoring, another 55,000. So let's take our patients and let's create some patients just like them out of our patients data set. There was that lower hospital mortality rate, not as robust in this one, that's interesting, but a lower direct cost and a lower sort of payer neutral reimbursement. And so really proximity for hospital revenue was better, and there was sort of less societal costs. So I think it works. Why does it work? I think maybe the most important thing is antibiotics, right? Time matters for this. Let me ask you another question. See your thoughts. So I'm going to ask you to be the provider, and oh wow, you guys are awesome. Already skipping ahead. A 55-year-old cough, malaise, opacities on the chest X-ray. Wife has COVID, has some muscular dystrophy and impaired swallowing, febrile, tachycardic, a little hypotensive. Their shock index, heart rate divided by systolic blood pressure is high. It's over 1. Satine 85%. Clearly sick. Someone calls and is asking for like, hey, should I give this person antimicrobials? So maybe you should treat within an hour. Should I treat them within 3 hours? They have COVID. They need some antimicrobials. They're higher risk because of their muscular dystrophy. Maybe they have pneumonia. Why don't you get a gram stain of some sputum and see what it is? I don't know. Do they call it an oyster of sputum in Georgia? That's what we call it in Seattle. Give me a good oyster of sputum. I don't know. I'll give you about another 15 seconds. Yeah, treat within 1 hour. Some people are saying treat within 3 hours. Okay, I agree. Good job. So antibiotic delays in the 90s, we have some very old data that's like, oh, if we give antibiotics in the ED, people do better than if we wait until a physician sees them 36 hours later because it was a Sunday when they came over Saturday night. Yeah, you don't do so well. This is Anand Kumar out of Canada. More recently, Ethan Pelton out of Utah looked at sepsis patients, and door-to antibiotic time was about 166 minutes on average, pretty good, a little over 2 hours. And the time to initiation, the longer you waited, the higher mortality. This was reproduced a little bit in some data out of the Kaiser system, also in California, as well as another system in Michigan. So it seems like antibiotics are the thing that is most useful, and probably risk-based antibiotics. So the surviving sepsis guidelines are, if shock is present, give antibiotics within 1 hour, the first column. If sepsis is probable, give antibiotics within 1 hour. If you're not sure and they're not in shock, then maybe do some rapid diagnostics to sort it out. But in general, mortality is higher if you're in shock. Mortality is higher if sepsis is most common. Stephanie Taylor looked at this at University of Michigan, 167,000 patients. Septic shock patients. Shock is defined as a low MAP, high lactate vasopressors. Infection was defined administratively in the data that someone received more than 4 days of antibiotics. And you can see mortality is really high in sepsis probable septic shock, still very high in sepsis possible septic shock. And yet the time to antibiotics was much slower in the shock is present not 100% sure this is sepsis. So something to think about. These guideline goals are hard to achieve, right? They really require urgency. Okay, that's about all I'm going to say about antibiotics, although ceftriaxone is definitely one of my desert island drugs. Let's talk about volume. So beautiful waterfall from the Olympic Mountains close to here. So another quick question, then we're going to dive into some heavy data. So 19-year-old diabetic presenting with necrotizing soft tissue infection to their right lower extremity, probably group A strep, right? That's most common right now. Restless, has an impending sense of doom, says they're going to die, and they're 19, and they usually aren't that dramatic, their parents say. Hypothermic, tachycardic, hypotensive, tachypnic, they have a low sodium. The referring team who's sending them to you says, how much volume should I give? We've given 20 mils per kilo and no change at all in vital signs. Yeah, this one's a little trickier. 20 mils per kilo, not quite the 30 mil per kilo guideline, but they haven't had any change. Should I start some vasopressors? Their heart work. Maybe I should give them balanced crystalloids as fast as possible, or a little slower, or give saline as fast as possible, or a little slower. Go maybe about another 15 seconds. You guys are doing amazing. 36 of you have answered, 40. A lot of folks saying hey, I should maybe start some vasopressors and then decide. Wow, this is great. You guys are all experts. Awesome. So about 2/3 are saying start some vasopressors and check it out. Okay, I love it. I don't know how much I have to teach y'all. Maybe this. Maybe your library doesn't go back as far as 1832. This is why we give volume for sepsis, right? So in what was defined or described as the blue stage of cholera in London, patients were very hypotensive because they had sepsis from diarrhea. They had liters and liters of diarrhea, and this was before John Snow, the epidemiologist, figured out it was coming from the water system because they had no sewer system in London. And so before he could lock up the pump that was causing cholera, a lot of people had this disease. Let me just read you directly from the journal article that was in Lancet from Dr. Thomas Latta, the first person to document the administration of IV fluids for sepsis. He says, having inserted a tube into the basilic vein, cautiously, anxiously, I watched the effects. Ounce after ounce was injected, but no visible change was produced. Still persevering, I thought she began to breathe less laboriously. Soon the sharpened features, sunken eye, fallen jaw, pale, cold, bearing the manifest impress of death's signet, began to glow with returning animation. The pulse, which had long since ceased at the wrist, returned to the wrist, at first small, quick, but by degrees it became more distinct, fuller, slower, firmer. And in the short pace of half an hour, when 6 pints, which I think is about 30 mils per kilo, had been injected, she expressed in a firm voice she was free from all unease, actually became jocular, fancied all she needed was a little sleep. Her extremities were warm, and every feature bore the aspect of comfort and health. Sadly, Lotta gave this bolus and then went to the pub to celebrate, and she died because she needed ongoing fluid resuscitation for her cholera. There you have it. Surviving Sepsis says, yeah, we suggest, not recommend, but suggest that we should use volume resuscitation within 3 hours. That makes sense. Evidence is not great. Let's walk through that. Where did the 30 mils per kilo come from? Initially, from a meeting in the 80s of a bunch of intensivists on the beach in Hawaii, just winging it. But more robustly from 3 big studies, Arise, Process, and Promise, which were studying goal-directed therapy, volume, blood, etc., versus usual care. And in general, people got between 28 and 34 mils per kilo. You'll recall there's no difference in outcomes in these studies. Timing probably matters. So older data compared with waiting to initiate fluids after 2 hours to starting the first 30 minutes, your risk of death was lower. Mortality increased about 9% relatively per hour. Feels like a lot. But of late, we've been sort of trying to figure out what's the right amount, right? And this is actually a really thoughtful study done on about 190,000 patients in a large healthcare system, looking at 25,000 different attendings. Oh, this was a premier healthcare database, so it was an insurance database. And the attending, the primary provider, was sorted by how much fluid they give. Are they a very low fluid attending, on average about 1.6? Are they low, about 3 liters? Are they moderate? Are they high, or are they very high? And here in the blue line in primary analysis, adjusted mortality is least in the moderate group. So maybe Goldilocks applies. And they said, well, maybe it's an impact of the hospital or some other systematic systems effect. But so they did what's called a fixed effects analysis in the orange line. And if it was the impact was the hospital, not the human making decisions, then that orange line would be flat. Here again, you can see that impact still was there. So it does seem that the observed differences in mortality were represented because of the amount of volume given. So started getting people to think about this. And we've known for a long time that excessive fluids are harmful, right? This is looking at, are you net even on day 4 of your ICU length of stay, net positive or net negative, based on a 20% change in your weight. And even or negative, their mortality, even out to a year, was less than if your fluid balance was positive. And we know when we think about fluid and start to think about, well, what are its impacts on all our different organ systems? In general, it's a little rough, right? You get cerebral edema, pulmonary edema, pleural effusions. You have high central venous pressure, which impacts your kidneys by backflow on the kidneys. You get gut edema, ileus, not good. So the first study to look at this was RIFS, which was said, let's look at volume. On average, in the first 72 hours in the PROMISE ARISE process studies, patients got around 100 mils per kilo first 3 days. In goal-directed therapy, the original study by Manny Rivers in Detroit, they got about 180 mils per kilo, which is a lot. They said, let's randomize people to less. And in the restrictive group, they got on average about 47 mils compared to usual care, got about 60 mils. 60-day mortality was similar. So you can see mortality on the y-axis, it's all about the same. Except maybe the people that got a lot of fluid, much higher mortality. We don't know exactly if that's the fluid or if that's the situation and the time that study was done. So the PEDAL group, a large research group, decided to do a randomized trial of this. And they said, we think we're going to need about 2,300 patients to study this. And we're going to study in the green arm vasopressor first. So you get a liter of fluid and then you get vasopressors. And you only get fluid if you really look like you need it. So sort of extreme hypovolemia. Versus let's give the fluids 2 liters. 1 liter to start, and then you get another 2 liters, and then you keep getting volume up to 5 liters before you get started on vasopressors. They actually stopped enrolling at about 1,500 patients. And the reason they stopped, there was good separation in restrictive versus liberal fluids. Restrictive fluids in the first 6 hours, about 500 mLs versus 2.3 liters. There was no difference. So 90-day mortality, about the same, 14 versus 15%. Renal replacement therapy, exactly the same. The restrictive group did have more use of vasopressors, longer use of vasopressors, but no difference in mortality. Okay, so maybe less is better. This also, and I'm not showing this data, has been shown in Africa in children, mostly with malaria, and in adults, mostly with HIV and tuberculosis. So what about a couple special populations? What about heart failure? So I'm going to go kind of chronologically. The first study that I could find looking at this was about 1,000 patients with septic shock and heart failure. Mortality was less in these patients with CHF and hypotension if they got 30 mils per kilo. It was about 23%. It was about 43% if they got less than 30 mils per kilo. Okay, that's fine. I can understand the mortality, but I'm sure all that fluid, they're getting intubated more. No, actually, they got intubated less. The group that got appropriate fluid resuscitation had a lower rate of intubation. Okay, that's interesting. What about renal failure, though? So this group, I can't find this published. It was a poster at an IHI forum looking at mortality rate in heart failure or renal failure patients. So these are, I think, patients on dialysis with severe sepsis or septic shock. If they received 30 mils per kilo, the fluids in the purple, their mortality was 25%. If they did not receive that amount, their mortality is higher. Again, a little counterintuitive. Kahn and their group looked at, again, volume resuscitation, and this was for septic shock, patients with heart failure or renal disease or cirrhosis, and they had no difference in time to intubation and no difference in their mortality. Another study, no difference in mortality. So when you take the four biggest studies and combine them in a forest plot, what we can see is when you combine these studies that favors 30 mils per kilo over 3 hours. This group called it the 30x30, 30 by 3. Okay, interesting. So maybe even those with heart failure, unless they're showing that their fluid is unsafe, that they're not tolerant of fluid, maybe they should get volume. Okay. Let's talk about fluid type. I need your help for this one. What is your favorite fluid to give? What's your preferred IV fluid? There's lactated ringers, there's normal saline, there's hypertonic saline, there's gelatins, mostly used in Europe, there's starches, albumin, blood. I know if there's a trauma surgeon in the audience, they're going to say blood. I got you. It works great in trauma. The LR, a lot of LR, normal saline ringers. A lot of people choosing balanced. Okay. Nice. Okay, well, let's look at that. Let's look at that evidence. Whatever my attending likes, I love it. Yeah, I'm so sorry. Every week, right? Preferences change. Hopefully, awesome medical student, I'll teach you a little bit so that you can make your own decisions. Plasma light, got some plasma light fans. Okay, I love it. The challenge with abnormal saline is it causes a hyperkalemic metabolic acidosis. Don't tell the surgeons. They were right all along. But they were right because they learned it because they were saltwater drowning patients in the 90s. It also, when is given to healthy volunteers, i.e. medical students paid $20 probably, causes afferent arterial vasoconstriction, right? Your kidney's like, I got lots of salt. And so it diminishes renal blood flow and GFR. People started looking at comparing balanced to saline. So balanced is either Hartman's in the UK, in Australia, which is LR, or it's LR or plasma light, and then unbalanced or saline is just normal saline. The initial study to look at this was from Australia, New Zealand, the split study. No difference, but look at how much volume people got. They got like a liter, most of them. Okay, fine. I don't think anything is going to be harmful or beneficial at just 1 liter. Salt, which was Vanderbilt's study, looked at this. And again, you can see on the x-axis, this is your total crystalloid through day 30. If you didn't get that much, 2 liters total over your whole hospitalization, your incidence of death or renal replacement therapy or acute kidney injury was the same. Once you start getting into bigger volumes, though, it does look like there's higher incidence of this combined outcome with saline. So that group said, well, let's repeat this. And so the SMART study looked at this, and they said about 15,000 patients randomized to balanced versus saline. Medium fluid volume was about 1 liter. Half of the patients got less than 1 liter, half got more than 1 liter. The combined incidence of death, renal replacement therapy, or acute kidney injury was lower in balanced crystalloid by like 1%. So, right, that means you need to treat 100 people with balanced crystalloid to save 1 person's life or prevent renal replacement, need for renal replacement therapy, or persistent renal dysfunction. That's not a great number needed to treat, but, there are 5 million ICU admissions in the United States, and so annually, so maybe using balanced fluids could prevent about 50,000 cases of this. Okay, that makes sense. How about if we limit that group to not all ICU patients, like we've been looking at, to just the sepsis patients? So this is the SMART study again, looking at just the sepsis subgroup. And it does look like your norepinephrine requirements went down in the blue line on the left with balance. It does look like your lactate goes down. And your 30-day mortality is less, odds ratio of 0.74. So that makes sense. That in septic shock, we think balance is probably better. In the SMART study initially was an EPIC study randomizing, using EPIC to randomize. It started in the ICU. And then they're like, well, we actually think we can do this starting in our ED. And when they looked at the group, the subset of patients where initial fluid was chosen in the ED, right, a fluid-giving machine, ED is awesome, right, initiate a resuscitation of volume. So thank you, eMERGE colleagues. There was lower mortality in the balanced group. So it seems like in the United States, maybe balance has lower mortality. What about in Brazil? Actually, really no difference, right? So saline versus balanced solution in this 11,000 patient study, about 4 liters over the first day. You can see here the cumulative mortality was high, 27% for saline, 26% for balance, but no difference. For those of you who care for traumatic brain injury in the ICU, do remember balanced had about a 10% higher mortality. So saline is probably better in that situation. I tend to use hypertonic saline in that situation. This group also did something really cool too. They said, let's look at the rate of infusion. So we'll call a bolus on a pump at 1 liter an hour. And we'll compare that to 1/3 of a liter an hour. There's no difference. You can see death in the orange color over time, comparing on baseline day 1, day 2, day 3, and day 7. No difference. Norepinephrine about the same. Blood pressure less than 70, about the same. Discharge home, the same. So if you're resuscitating a leaky colander, trying to fill up a leaky colander with water, maybe instead of pouring it all in at once, maybe pouring it a little slower might be useful. Okay. So we think balance is better, not in Brazil. We think faster versus slower are the same. Okay, I like it. The Simon Finfer in Australia, New Zealand looked at this in New Zealand, looked at the plasmolite, which is sort of a balanced solution, versus saline in about 53 ICUs. Pre-randomization fluids were about the same. They had a little bit of crossover, which happens, and they showed no difference. So maybe no difference. Okay, interesting. This was all ICU patients, not just sepsis. The Clover study said, let's look at sepsis, right? Remember, that was no difference between vasopressor arm versus up to 5 liters of fluid before vasopressors. Sorry. And mortality for ringers was about 12%. Mortality for saline was about 16%. So again, lower risk with balanced, right? And that's reflected here. You can see the balance in the light gray. Okay, interesting. When Naomi Hammond, who's an amazing PhD nurse researcher in Australia, did a meta-analysis, really no difference. Maybe a slight effect on all ICU patients to balanced, although the confidence interval of this forest plot crosses 1. So surviving sepsis would say, we suggest using balanced. Please don't use gelatins. That there's a lot of studies from the 90s and 2000s around that in Europe, clearly harmful, but we think balanced slightly better. But if all you have is saline, that's going to work too. How do we individualize this for our patients? We're basically trying to do this, right? We're trying to raise their preload to see if their cardiac output goes up. How can we do that? Lots of different ways. Non-invasive cardiac output monitoring. This is done in Denver. They use a relatively complex schema of assessing for fluid responsiveness using a passive leg raise maneuver and a bioreactance device. So a device with 4 stickers on your chest that looks at electrical phase shifting through the thorax as a surrogate for pulse pressure. And they showed much less fluid in the group that used the device, fewer patients requiring renal replacement therapy, fewer patients requiring mechanical ventilation, more patients discharged home, no statistically significant difference in death. Passive leg raise, when studied in a meta-analysis by the group in France, pretty good, right? Passive leg raise the legs using the bed, right? If you just grab someone's legs and put them up, things will change because they're wondering what you're doing. But head up with the bed, lower the head, raise the legs, wait a minute to 2 minutes and see what happens to your cardiac output. So you have to have some surrogate for cardiac output. Okay, it could be ultrasound. Show you one way to do that in a second. Could be some non-invasive cardiac output monitor. I don't always trust the values, but I trust the trends. Maybe even if it's a low-tech thing, maybe that'll be the heart rate going down. So cardiac output going up by 10% has a pretty good area under the curve. Pulse pressure variation in intubated patients, looking at change in the pulse pressure as they get a mechanical ventilator breath, that they're synchronous with the ventilator, works really well at big tidal volumes like 12 mils per kilo. We don't do that anymore, right? 8 is kind of the new 12. And a lot of people have ARDS, so we're there at 6 mils per kilo. I think this is super interesting. I've started adopting this after learning about this. Is if your pulse pressure variation is less than 12% on 6 mils per kilo tidal volume, that would say negative. My patient would not have a higher cardiac output if I gave fluid. But it's a pretty low tidal volume. So if I raise the tidal volume to 8 just for a minute, don't think it's going to hurt them, and keep it there for a minute, see what happens to the pulse pressure variation. If it goes up by 2.5 or 3 points, then they're fluid responsive and would benefit from fluid. We've started using a lot more ultrasound now to do this. And so we use increased preload with a passive leg raise. You could give a fluid bolus, even as small as 50 mLs, given pretty quickly with a syringe can work, and measure the cardiac output, the blood flow velocity in the carotid artery. You can measure it in the heart, but often it's hard to do. Carotid's really straightforward. Just put some pulse wave Doppler on there, measure the velocity. You could measure the volume time integral if you want to get really fancy, but just the velocity, if it goes up by 20%, then that would suggest that your patient is on the steep part of the Frank-Starling curve. If you increase their preload, their stroke volume will go up. I tend to use the right carotid since it's the second vessel off the aorta. I'm right-handed. I like to work on the right. Obviously, as an intensivist, I negotiate with my bedside nurses which side they need to work on, and I get the other side. So I can do it from either side. Even using the pulse oximeter for some devices that show the pulsatility index, how strong the pulse is, can work. And so I put it together like this. This is kind of how I approach shock. This is a great Blue Sky or Twitter feed by this person, Critical Cultivation, who draws out lectures that they go to. If your pulse pressure, systolic minus diastolic, is narrow, less than 40, it's a stroke volume problem. So either they need fluid, or their ventricle doesn't work, or they have tamponade or tension pneumothorax or massive PE. Can't get preload to the left ventricle, or can't get preload out of the left ventricle. If their diastolic blood pressure is less than 50, or their diastolic shock index, their heart rate divided by diastolic is high, over 2 to 2.5, they have a vascular tone problem, right? So they are vasodilated. Could be from anesthesia, could be from sepsis, could be from anaphylaxis. But in that case, then I think norepinephrine is helpful. And so I put together my fluid this way. So are they volume tolerant? Is it safe? I usually use ultrasound to assess the lungs. Are they volume responsive? If I think they need a lot of volume based on history, they're truly hypovolemic, nausea, vomiting, diarrhea, not eating or drinking well, they have DKA, then I give them a lot of volume, 30 to 50 mils. I give the 20 mils per kilo quickly, and then I give the remainder over 3 hours. I think most sepsis patients tend to fall in the moderate, so I usually give people 30 mils per kilo, first 20 mils per kilo quickly over 10 minutes, remainder over 3 hours, and that still will meet the 3-hour goal. If I think they don't need volume, I may give them not much volume and document why. And of course, as an ICU doctor, I got to say, always be diuresing. You can use complex methodology on the left, hepatic vein Doppler, flow reversal, E to E prime, or you can just say, hey, the patient's in the ICU, they need Lasix. Okay, we have maybe about 10 minutes left before questions. Let's dive quickly into vasopressors. I'm going to ask you another question. So, 19, I'll go back to our 19-year-old. They're tachycardic. They have a necrotizing soft tissue infection. They're waiting for OR space. They're restless, hypotensive. And someone said, okay, you told me to start vasopressors instead of following responsiveness in that last question. Now, what should I start? Norepinephrine, vasopressin, phenylephrine, epinephrine. No vasopressors because they don't have a central line yet. Lots of people saying norepinephrine or Levophed by its brand name. No anesthesiologists in the audience want to be brave and say phenylephrine. Okay. And pediatricians, maybe until recently, have been on the epinephrine best, although maybe newer data in kids that Norpi is best for sepsis. Okay. Kind of norepinephrine, 80%. I love it. I'm pretty simple-minded about vasopressors. I think of them like a big speedometer. Beta on this side, the butamine, really an inotrope, isoproterenol, old-fashioned inotrope. Epinephrine, a little bit more inotropy is what I tend to use it for. Norepinephrine, more alpha, vasoconstriction, and phenylephrine, pure vasoconstriction. A couple others, angiotensin 2, I don't have access to. Methylene blue, interesting, soaking up nitric oxide, maybe more helpful in liver injury. Milrinone, another inotrope. Dopamine, which is just an old-fashioned drug that's converted to norepinephrine, so I don't use it. And vasopressin. I agree with you. Norepinephrine is like it's like the Subaru Outback of vasopressors. Like it's like a pure Northwest or mountains of Georgia sort of vehicle. Take you to the opera, take you to the theater, to a fancy dinner where you're wearing a tie, or it can take you out in the mud to the mountains. So I'm a big fan of norepinephrine. Don't wait for central line. So in Michigan, when 2/3 of patients started receiving vasopressors peripherally in the navy blue, dark blue on the left, most were alive and off vasopressors and never got a central line. About 20% of all the patients got a central line. And so really no difference. And it really seemed here in this group, it was by hospital location. Peripheral infusion, starting peripherally is faster. And really, there was very little tissue injury. That said, you should probably have a protocol for your awesome bedside providers, the nurses, to be watching the IVs for which vasopressors are going through. Some early observational data about very early vasopressors. So a couple questions ago, you all said start some vasopressors. I agree. Vasopressors starting at a very low resuscitation fluid amount here in this study, which is observational out of Brazil at 5 mils per kilo. And over time, the resuscitation fluids stayed lower. And it looks like in this observational study, much lower mortality. So I do tend to start my vasopressors after that first liter, which is usually about 10 mils per kilo for most of our patients. I'm a big fan of vasopressin. Lots of studies showing it reduces your need for renal replacement therapy. Won't dive into these. Other than one, which is super cool, the first AI study. So take an AI computer and give it some points. So it plays a game with a bunch of patient data so that every hour the patient's alive, get a point. Patient dies, lose 20 points. Lactate going down, get a point. Blood pressure going up, get a point. Decreased SOFA, which is a sequential organ failure assessment score, a severity score, points go down. And basically, the computer ended up starting earlier than the clinical teams. So starting vasopressin about 4 hours from shock onset. Started vasopressin in many more patients. started at a pretty low norepinephrine dose at 0.2 mics per kg per minute. Adjusted odds compared to usual care was lower. So I do, in my practice, start vasopressin. I also start steroids when my norepinephrine gets to about 0.2, or sometimes if the patient looks very sick, I might even start when the norepinephrine is at 0.1. I think the future for vasopressors are going to be multimodal. So you may have some vasopressin for low systemic vascular resistance or renal injury. You may have some angiotensin II for ARDS or renal injury where your body doesn't make angiotensin II. You might have some epinephrine for low EF or an inappropriate normal lactate, which is a marker of low epinephrine in the body. And in general, a lot of norepi. You might even add some methylene blue in the center. So I think this is where we're headed. So I'm excited. And for like the medical students in the audience, I don't know if anyone's told you, half of what we're teaching is wrong. Don't know what half yet. This is probably what you'll be doing different than us in the future. Okay, let's talk about resuscitation endpoints real quick. Tell me more about how you decide your patient's resuscitated. What do you use? So lactate clearance, you could use reduction in vasopressors, central venous pressure, MAP, lactate trend. Some people used to use urine output. Yeah, urine output. Yeah. So we're looking at organ perfusion. Like that. Okay. This is kind of a tough one, right? Because you know you do it, but you're not. Sometimes if you're an unconscious expert, you may not know how the patient looks. I love that, right? Are they less anxious? Does their sense of doom gone away? Do they look awful? Map and blood pressure. Look at the patient. I love it. Okay. I agree. I think it's complex. Attending preference. Yeah, I know. It happens. We used to think higher MAP was better. This is an older study by the French, right? They're looking at MAP. MAP in French is PAM, right? Pressure arterial Mayon. They did a higher MAP versus a lower MAP. The low target group, remember, if you ask someone to keep the MAP above 65, it's probably going to be higher. And here you can see the MAP was often around 75 compared to 85. And there was no difference in mortality. Okay. More atrial fibrillation in the high target group. In the 65 trial, a really large study done in the United Kingdom, 65 ICUs, elders over 65 with hypotension that was vasodilatory, MAP of 60 to 65. Median, about half of them, their MAP was above 67, half below. Or MAP greater than 65, the median MAP was higher, 73. Shorter duration, lower total dose of norepinephrine, maybe slightly lower mortality in the permissive hypotension group. So I'm a big fan of saying MAP should be 60 to 65. I used to say, well, every once in a while, if someone's not looking great, maybe not making urine, maybe I should try a higher MAP and see. And this just came out like a couple weeks ago. Japanese study, about 100 patients, so pretty small. And it was open randomized trial. So randomized people, but people knew what was happening. So they weren't blinded to the blood pressure. And they looked at a MAP target of 80 to 85 versus 65 to 70 for 72 hours or until they're off vasopressors. And it looks like the high target group actually had a higher mortality, a lower probability of survival. So maybe the higher MAP is harmful. So when I raise the MAP to see if that helps my patient think about individualized care, I might go to 75 to 80, but not really higher. Modeling is something else that I think you should use at the bedside. So standard modeling score is based on the kneecap. So you can see the kneecap on the left is a modeling score of about 2. It comes off the kneecap barely versus 4. The entire leg looks marbled. And that shows pretty good predictive value and something you can trend. Andromeda shock, they've just finished enrolling. Stay tuned. They're looking at data, use a pretty complicated bedside algorithm of looking at pulse pressure diastolic blood pressure to decide fluid versus vasopressors. They looked at cardiac dysfunction and thought about if they should use inodilators, milrinone, to help squeeze the heart. And ultimately, they used capillary refill. So trying to achieve a capillary refill of less than 3 seconds. And I think this is where it's at. So in their initial study, capillary refill did better than lactate clearance, probably because you're looking at the patient. Remember, it should be usually on the thenar eminence or on the sternum. That's where it's best validated. I also will use temperature. So I'll look for a cold line. So, is their hand cold to the wrist, to the elbow? That can kind of help me with cardiogenic shock too. So putting this all together, what should we do? Well, you should probably expect sepsis, right? In a single incident study done across all the ICUs of the world that had an email and could answer, 87% of the world's shock was septic shock. So it happens. Antibiotics are emergency medications, just like epinephrine, bolus, and cardiac arrest, we think is helpful. Antibiotics we know are helpful. Unless there's a source of ongoing fluid loss, ongoing fluid resuscitation after the initial bolus may be less helpful. Balanced fluids may modestly improve outcome, so why not? I tend to start vasopressors often and early. And if you're not meeting your resuscitative endpoints, maybe think about reevaluation. Do you need source control? Do you need a surgeon or a radiologist to drain some pus from somewhere? Is your patient have something different than what we think we're treating and we're on the wrong antibiotic? So time to step back, go slow. Okay, thank you. This is my email. I'm on Blue Sky. And I wanted to say, if this was fun for you, come to the Sepsis Forum. It's free, virtual, online event on October 23rd, where we tend to do panel discussions with experts with just a few slides, way fewer than I had, and a discussion of complex topics. So we're going to talk about social determinants of health and how to integrate into different cultures around sepsis, talking about the tension between guideline and individualized care, and always have a perspective from a patient. So I hope you can make it. So thanks very much. I'm going to stop sharing and hopefully maybe a few questions. Thanks for your time.
Hey, Dr. Carlbom. This is Dr. Michael Vidal, PGY3 internal medicine. Got a question for you. So you went over some really cool ways to measure fluid resuscitation. Carotid, measuring the velocity across carotids, looking at diastolic blood pressure. What are some really quick ways that you can evaluate somebody, like say in the ED, if they're coming up to you and you don't have access to all those tools?
Yeah, that's a great. Thank you for your question. That's a great question. I believe in high tech and low tech, so I carry an ultrasound on my waist because I'm an ultrasound nerd, and yet I also love examining people with my hands. And so for me, my mentor taught me long time ago to shake people's hands. When you shake their hand with usually the right. Feel their radial pulse. So just slip your other hand over their wrist. Hi, my name's Dr. Vidal. I'm going to take care of you today. What's going on? How can I help? Feel their pulse. So a couple things: fast or slow, feeble, low pulse pressure, or firm, bounding, and you can do this experiment next time you're with all your friends and, see who's had their morning coffee and is a little volume depleted, or if someone worked the night shift and didn't have enough fluid, right? Feel their pulse. It'll feel kind of puny versus someone who's, just topped off their volume. It'll feel bounding. You also have skin temperature. So are they cold? In which case you might be like, oh, let me just feel at the elbow here. And their brain works because they did a socially appropriate thing and reached out and shook your hand. So I love what I call the Copus handshake. That was my mentor, Michael Copus, who invented paramedics in Seattle. But I would call it, your patient handshake. So great. Thanks for the question. I know for me, I have to admit, I used to be like a full do all the fluid on everybody and more. And now I've sort of, maybe the pendulum swung a little bit back towards more early vasopressors. And I'm always, one of the sessions we're doing at Sepsis Forum is around this tension between individualized care and protocol care, because right, my protocol people are like, why didn't you give more fluid? And I'm like, well, because I don't think it would have helped them. And they're like, just chart that. I'm like, okay, I'll try. Um, I think finding that on average, the 30 mils per kilo probably helps most people, like 90%. But there are like that 10% where you're like, I think this is actually going to harm them. So yeah, I feel that tension. It's tough. And be kind to the people that remind you to chart better.
I think that's a great segue, Dr. Carlbom, to mention that we just had some sepsis smart phrases go live on July 29th. If you type .sepsis list, you'll have some fluid options for that 10% that you might not feel comfortable. For a lesser targeted amount, that does your documentation for you, as well as no fluids. So just wanted everyone in the audience, and that was a great segue. Any other questions before we finish up?
Okay, we have a question. It said you had mentioned steroids. Could you elaborate when you would introduce it?
Yeah, having worked a lot in our COVID ICU, I will tell you my intellectual bias, and that is steroids, I think, are helpful in shock and in ARDS. That said, the studies are not great, right? Decade by decade, different studies have shown different things. But I think on balance, we're learning and in meta-analysis and in Cochrane meta-analysis, seeing that steroids are pretty beneficial. And so I usually start my steroids when I get to 0.2 mics per kg per minute of norepinephrine equivalent. So either norepinephrine at 0.2 mics per kg per minute, or norepinephrine at 0.1 and plus vasopressin. And I tend to stick by the Anand study, the APROX, that did the steroids, hydrocortisone 50 Q6, Fludro. Our pharmacists, we can't figure out how to give 50 micrograms. It's so small, so we give 100 micrograms. It's a pill. I do that for 7 days or until ICU discharge. And I think this aligns with sort of Cape Cod and pneumonia being beneficial, and our MICU, pneumonia definitely, along with bacteremia, has the highest mortality of sepsis. So that's when I tend to do it. And I feel like it's helpful. I also use it for severe ARDS, sort of per the DEXA ARDS trial. But yeah, that's a fun talk because decade by decade, the recommendations changed. Not a hugely positive study, but definitely had a little bit lower mortality and lower what I think are patient-important outcomes, shorter mechanical ventilation, lower vasopressor days.
Okay, this one says, can you give any recommendations for maternal sepsis? There is a recommendation of early fluid resuscitation and antibiotic therapy within 1 hour of suspected maternal sepsis. What are your thoughts on this?
Yeah, I think maternal sepsis is, the leading killer worldwide, and it's a big deal. And so I do think it's a medical emergency, and I think trying to apply those guidelines are important. I think most moms are probably have normal cardiac function. And so I think in general, the fluid is safe, and I think antibiotics are safe. I think even an antibiotic steward would say, we would rather you give antibiotics, even if you're not 100% sure, stop them in 2 or 3 days if it wasn't an infection, versus withholding antibiotics. So I think it's great. I do know the guidelines from those groups are a little slow to come out, but I know we've had lots of presenters at the Sepsis Forum and the Pacific Northwest Sepsis Conference around maternal sepsis, and it does seem like it's probably the right thing to do. And so I treat them just like other adults with sepsis.
All right, I think we're at time. So Dr. Carlbom, I just want to thank you again for presenting. And if you're ever in the Southeast and going through this area, we certainly would welcome you here in person the next time if you ever get this way. But
Awesome.
we really appreciate you educating us today. Thank you, everyone.
Thank you. And you guys, I don't know if your audience knows, but you all are doing so well on sepsis. Like I'm so impressed. I've seen some of your stuff before presented that you presented, and you're really on top of it. So keep it up.